Hello and welcome to the Evidence-Based Urgent Care Urgentology Podcast. I'm Joe Toscano. I am on the editorial board of Evidence-Based Urgent Care and also the senior research editor for the sister EB Medicine publication, Emergency Medicine Practice.
And I'm Tracy Davidoff. I'm the editor-in-chief of Evidence-Based Urgent Care. Joe and I have been involved in urgent care practice and education for many years, and we're really excited to bring to you this new program from EB Medicine, the Evidence-Based Urgentology Podcast. Our goal for this podcast is to review one of the recent issues of evidence-based urgent care and highlight some of the important things that have come out of that issue, the learning points, and potentially practice-changing information from the piece.
We hope that the podcast will be valuable in and of itself, but it'll also whet your appetite to delve more deeply into the issue, to hone your practice, and even get some CME credit.
And even if you've read the issue already, Joe and I hope to reinforce the important points and solidify important concepts to improve your learning as a result.
If you create an account at ebmedicine.net, you can prescribe and purchase the issue. You can check out the interactive clinical pathways they have there, and you can get up to 4 hours of CME credit for completing this one issue. Hey, you've already started your CME journey by listening in.
And you can also subscribe for a full year so you won't miss anything. At the regular price, that's a great value. Be on the lookout for occasional promos, sales, and special offers to make it that much easier.
Today on the podcast, we are going to talk about the April 2024 issue of Evidence-Based Urgent Care, which is about electrical injuries, management of low voltage shock and burns in urgent care. We want to first off thank the authors of the original article, Nathan Morrison and Robert Olympia, who are both ER physicians out of Penn State Medical Center in Hershey, Pennsylvania.
And then we'll also thank the peer reviewers, which would be Margaret Carmen, who is a nurse practitioner in emergency medicine from Chapel Hill, and Martha's Vineyard. That sounds like a lot of fun.
Nice.
And of course, our very own Joe Toscano, who also peer reviewed this edition. So we're going to talk about electrical injuries, which is probably not something we're going to see very often in the urgent care setting. Initially, I thought, why do we care about this? Because, I think I can count on one hand how many times I've seen an electrical injury in urgent care. But you know what? It is going to walk in the door. So you really should have a working knowledge of what we can deal with and what's a 911 to us. So just to give you a little bit of background, there's actually about 1,000 deaths per year due to electricity in the United States. But on top of that, there's probably another 30,000 that are non-fatal shocks annually, and probably quite a few more that don't seek care. So it is something that happens fairly frequently. Most injuries are due to a couple of defined things: lightning, household electricity, the old knife to the toaster, or the home repair gone wrong.
Ouch.
I know that's happened multiple times in our house. Or occupational exposures, which are more frequent than your average Joe getting shocked. The injury can be separated into both low voltage and high voltage, with low voltage being considered to be under 600 volts and high voltage over 600 volts. Now, if you think about it, the U.S. standard wall outlet is about 110 volts, but our major appliances are usually 220 volts. That's most of North America. In some other countries like Europe and Asia, 220 is generally the standard wall outlet. Low voltage injuries, more common in children. Think children chewing or playing with the power cords or sticking their little fingers in the outlets. Or the higher voltage injuries, which are more common in adults. And again, going back to the occupational exposure. Think about power lines, how much electricity is in them. That would be 100,000 volts. So that's significantly higher than your low voltage injury.
Cool. Hey, we should probably talk a little bit about the physics of electricity before we talk about what it does as it flows through your body. Harkening back to high school or college, talking about physics, electricity is the flow of electrons from a high voltage gradient down to a low voltage gradient. Voltage is one of the common ways that we measure that electrical flow. It's a measure of the strength of the gradient. It's a product of the resistance of whatever the electricity is flowing through, as well as the amperage or the strength of the current. The strength of the current is actually relative to the number of electrons that are flowing through from that high to low voltage. Two kinds of electricity, DC or direct current. This is where there's constant flow in one direction of those electrons. Examples include the batteries that we use in all of the stuff around our house and our cell phones and all that, as well as the flow of electricity in an electrified train track or a trolley track. Also the electricity in a hybrid vehicle or an electronic vehicle. And then lightning is also direct current. Alternating current, or AC, is what we have in our house and in commercial applications. The electrons actually are going back and forth at a particular frequency. That's the hertz that you hear, household current's usually 60 hertz. And it's just better for certain applications is why we have alternating current in our homes. a little bit of a difference in terms of how that affects the body. In general, DC doesn't feel as strong for the voltage as alternating currents, just in terms of how our body senses it. As well, this concept of let go voltage, where we actually have the ability to let go, or the electricity ourselves makes us let go. It takes higher voltage of DC than AC to reach that let go potential. And then alternating current physics of this is a little bit complicated, but that does, for any particular voltage, have a little more profound effect on tissues and causes more tissue damage, whether it's skin, muscle, or whatever the electricity is flowing through.
All right, that's great. So, we're not really going to dwell on high voltage very much, but just for some perspective, a lightning strike is 10 million volts for just a millisecond. So think about the amount of electricity that is in a
Tons of,
lightning bolt. That's just
yeah,
that's just crazy to me. And there's about 300 injuries due to lightning, about 100 deaths per year in the United States. Hopefully, we'll not see that in urgent care, but it's possible that somebody nearby or somebody who happened to survive might end up walking into your urgent care. So the differential diagnosis of this, either you're shocked or you're not. I mean, it's pretty simple. But if you think about it, maybe it's not. I had a patient once who was in a car that he thought was struck by lightning. Was he really shocked by the lightning or was the car just shaking and it scared him? So sometimes it's a little tricky to figure out whether or not they were shocked. But the type of injury that a patient may end up with after they've been shocked is really a broad differential. So that's where you really have to do your thinking. Shocked versus not shocked is easy, but what injuries might occur is a little more thought provoking. So the injury that occurs may be immediate, it could be delayed, or it could be a longer term sequela, and it can affect multiple organ systems. Pretty much anything in the body can be affected by the electricity. On top of that, aside from the injury of electricity, you can get injuries from being thrown from the electricity. When you let go, you can get thrown backwards, or you can have a titanic muscle contraction that can cause injuries. There's reports of people with large shocks that have actually broken bones
mm,
just from the muscle contraction.
dislocations. Yeah.
So, Joe, if somebody shows up with a electrical injury, what's the first thing that you should think about?
And I think it's cardiovascular effects, and a couple of reasons for that. I mean, electricity goes through your heart and it stops, it's going to have an immediate and profound effect. We're thinking about electricity in our heart probably more than any other part of our body. As we're looking at EKGs, we're really conscious of normal electrical current going through the heart, and electrical shock can disrupt that. It's also true that the resistance of cardiovascular tissue is one of the lowest in the body. So as electricity is coursing through from wherever it starts to wherever it exits in the body, the heart can be one of the paths of lowest resistance for it. So it tends to flow that way. The cardiovascular injuries that are seen tend to be worse in lightning and high voltage situations. Of course, that makes sense. In those situations where there's that degree of energy flowing, more likely to see asystole or VFib. In those lightning victims, let's say, who don't survive, that's usually going to be their cause of death. Both of those are pretty bad, unless you have somebody with an AED there and the moxie to shock someone in the rain. That person's probably not going to make it. But a variety of other things are seen as a cardiovascular effect of electrical injury, other arrhythmias, PACs, PVCs. You might see VTAC that's either sustained or paroxysmal, and also heart blocks. The interesting thing is that when you think about this and the heart actually changing as a result of electrical current flowing through it, it seems like it should be kind of permanent. And in some cases it is, but a lot of times those changes that are seen in survivors of electrical shock do get better. Whatever the abnormality on their EKG or with their cardiac tissue will get better with time. You might want to treat it in the meantime, but it could take up to 3 weeks to get better, but you may see resolution of those initial effects. I mentioned EKG just in terms of our consciousness of electrical activity in the heart. That's our main way of evaluating the heart after electrical injury. We're going to do that for really every patient that we see. You might be able to identify any arrhythmia at the time you're doing the EKG. It may take more extended cardiac monitoring, but you'll also get a sense of the conductive capacity of the cardiac tissue, the myocytes with an EKG. There are reports of ischemia after electrical shock. There might be myocardial damage, let's say, from the electricity flowing through it, but actually producing ischemic injury where there's loss in blood flow, it's pretty rare. And usually it's not due to the usual cause like a blood clot or it's thrombotic, but maybe due to spasm of the coronary arteries. Because of that, and because if there is some myocardial injury as a result of electrical shock, doesn't seem to really have much prognostic value measuring troponins, though it might be intuitive that, oh, heart injury, I want to measure troponins. It hasn't really proven to be very helpful in the management of these patients. Negative results don't rule out a cardiac injury. And if you have a little bit of a troponin leak, unless it's huge, not really found to be prognostic. So that's kind of good for us in urgent care because we don't have access typically to troponin measurements. If you do see arrhythmias in a patient, you're going to treat them just like you would if they weren't shocked and somebody had VTAC, let's say, or heart block. Then use your ACLS measures and treat the same way. There's nothing specific or different that you would do. What's your number two, Tracy, for this in terms of what sorts of injuries occur when somebody gets shocked?
I would say probably neurologic, numbness or tingling in the hand where you touched it. Some people may have some weakness as well. So, like a peripheral motor or sensory damage, which is pretty common in the extremity where the entrance wound would be. You also got to think about loss of consciousness or amnesia because brain tissue is also very sensitive to electrical activity and it can cause both of those things. The injury in that case is usually due to a direct thermal damage of the electricity coursing through it. So those would be your neurologic concerns.
hmm Speaking of thermal damage, that's kind of what happens with skin as well. When you think about it, it's like, well, what's its function? It has a barrier function. And when it's injured, basically it's damaged, and the damage occurs through thermal injury. Interestingly, the resistance of skin to electricity is pretty high. It's actually close to bone, and calloused skin is actually more resistant to electrical flow. But it's really where we come in contact with electricity. Typically, somebody's touching it, or it might be in a mucous membrane like the mouth with the kind of classic toddler biting on an electrical cord. But most of the time, the contact's going to be with skin. And so that's one of the commonly injured organs, but it tends to be pretty protective. When the skin is dry, it's less likely to burn or conduct electricity. Wet skin, a little bit more conductive as well. The electricity is going to move across the skin in that wet layer as it goes to ground. In that case, skin's a little bit better conductor and it's less protective of the internal organs. There's a cool photo in the issue of a Lichtenberg figure. It is figure one on page 6. And it's that ferning pattern that classically shows up. I haven't seen this in real life, but you can see pictures when you read an article about electrical injury, particularly lightning strikes. These Lichtenberg figures are that electricity actually traveling over the skin and causing an erythemic type pattern, basically a first degree burn. It's really cool kind of pattern when you think about it. It almost looks like lightning on the skin somewhat. High voltage, again, because of skin's high resistance, we're going to see more injury with high voltage type. That may actually penetrate through the skin and into the bone, particularly the periosteum, which has a little bit lower resistance than the harder bony matrix internally. But with those high voltage injuries, it can actually damage the bone, get osteonecrosis with obliteration of the bone matrix, the internal marrow. Muscle has intermediate resistance and can be a pathway of electricity to flow through the body. So muscle can be injured. You can get myonecrosis, rhabdo. Rhabdo can lead to acute kidney injury. And then if there's swelling of the muscle in a tight compartment, you can get a compartment syndrome as well, secondarily.
Small cells concerns, probably less common, certainly not in urgent care, but ER definitely.
Mhm.
Any damage to muscle can cause some leakage into the blood system, which can cause acute kidney injury. Other less common things, but definitely of concern and something that we should be looking for. Cataracts, again, that would be long term. I don't think we're going to see an acute cataract, but possible. Traumatic hyphema in the eyes. You can get some blood in the anterior chamber due to the electricity coursing through the eyeballs. Vitreous hemorrhage, also possible. And then going back to that neurologic injury, you can get some optic nerve injuries, more common with the high voltage injuries or lightning, but also possible. Ear barotrauma can occur due to increased pressure in the middle ear. You can cause some barotrauma, which can result in hearing loss. It can result in tinnitus, and it can also result in some vertigo. So, man, I mean, like every body system can be affected. This seems like a lot. So the patient walks into your urgent care with an electrical injury. What do you do?
Yeah, it's almost like a trauma kind of, you want to do your primary survey initially. The patient's walking and talking, you're evaluating your ABCs at that point. They're perfusing, their airway's okay, but it's important to step back and think about the ABCs because that's your first step in evaluating these patients. And obviously, if there's something wrong, you're going to work to stabilize it. If the patient passes that primary survey, doesn't need any intervention, you'll move on to your secondary survey, kind of like an ATLS assessment. You want to look everywhere, touch everywhere, ask the patient if they have pain or tenderness. Try to think about where the electricity entered the body. Sometimes it's obvious because there's an entry burn. Think about where it exited the body. Kind of hard sometimes to determine the pathway just ahead of time. But if you ask where the patient has pain and touch and evaluate how the patient move around, you can make a better assessment of that. Obviously, patients with unstable vitals or airway compromise or dysrhythmias, you're going to be calling 911 as you're beginning to stabilize them. And then what you do from there really depends on the capability that you have in your center. What's your approach, Tracy?
Well, obviously, once you've decided that you're not screaming, call 911 and freaking out because you have somebody unstable in your clinic, you want to try and do a very focused history. You got to figure out the mechanism of injury. How did it happen? Detailed review of systems because electricity can affect literally every system in the body. You want to make sure that you go through everything. Focus on the cardiac. Is there any palpitations, any chest pain? Did they have a loss of consciousness? You wanna look for discolored urine, did they void since the injury, and what did that urine look like? If they haven't done that, maybe you should have them do that. Are there any skin changes, any wounds anywhere? Did they have a loss of consciousness? Are they having amnesia? Because that would indicate to you that there's more of a significant injury there than just a simple shock. You may need to get some history from bystanders if they can't really tell you what happened. Ask the people that are with them, what did they see? What do they think happened? And the physical, again, also depends on exposure. If it's a simple shock a few days ago, it's a little less of a physical exam than if it's someone that can't really give you a history and you have to go through the whole body. Again, high voltage, you're going to call 911 right away. You're not going to wait to do all of this detailed history and physical. You're just going to make sure that you get the patient to the hospital as soon as possible. Primary or secondary survey approach, we talked about that. If it's minor injury and you've decided you're going to keep the patient, now you want to do a focused exam from head to toe. You got to inspect the whole body, and this includes undressing them. A lot of urgent care patients, we don't need to undress them. We can examine them fully dressed. That's something that helps us be fast. But in this case, you're going to want to really make sure that you look everywhere. You're looking for that entrance wound, you're looking for that exit wound, keeping in mind it could be on the feet. Remember that electricity tries to ground itself.
Mhm.
So it's trying to find a way to escape. So it's going to look for the easiest path to get out. And in some cases, that may be the feet, and the patient may not even realize it. This concept of distracting injuries is a real thing. If you're focusing on that horrible electric shock you got in your hand, you may not realize that you also have a wound on your foot. So you want to make sure you do that. Palpate every portion of the body looking for musculoskeletal injuries, and you want to go through passive range of motion and active range of motion with everything to make sure everything's working. And as I said, don't forget about those distracting injuries. Did they hit their head when they fell down? Did they have some other injury that they're not focused on because they're more focused on the shock itself?
All great points. How about diagnostic tests or anything useful to evaluate these patients?
I mean, again, a lot of it is going to consist of what you're capable of doing in your urgent care center. If it's somebody you're sending out, probably not useful to do much, but if it's somebody that you're going to keep, you're going to do a little more. So based on your history and physical, you want to try and divide the patients into low risk criteria and high risk criteria. Now, our low risk criteria is people with that low voltage injury that we were talking about, that less than 600 volts. They don't have any symptoms, they haven't had any loss of consciousness, and they really have no findings on PE. That would be the person that got shocked and I feel fine. Maybe I got a little anxious. Maybe I felt the shock, but I'm doing okay now. In those people, you can do an EKG to exclude any arrhythmias. Remember, not everybody feels their arrhythmias, so they may not appreciate that their heart's skipping beats or that they're going a little too fast. And no other testing is needed after that if they're asymptomatic and they have a normal EKG. But if they have those low risk criteria, but they're having some very mild persistent symptoms, a little numbness and tingling in the hand, feeling anxious, maybe some palpitations, and they just have like a little cutaneous burn, you can do an EKG. You probably should do a UA to make sure they don't have any myoglobinuria going on there. And if all of that is normal, they should be monitored for about 4 to 6 hours just to make sure that no arrhythmias develop. If they remain stable for that 4 to 6 hours and they have a normal EKG, you discharge them. Keeping in mind, not every urgent care has the ability to monitor somebody on an EKG for 4 to 6 hours or even the capability to hold somebody in their urgent care for 4 to 6 hours. If that's the case, then you're going to have to send them to the hospital to be evaluated and monitored for those 4 to 6 hours. So, what about the late presentations? I mean, a couple times I've had people that have come in 6 to 8 hours after that electric shock. They just want to make sure they're okay and they're asymptomatic. In that case, you can do an EKG and send them home if they don't have any symptoms. But if they're still having symptoms after that 4 to 6 hour period, it's time for evaluation in the hospital. Remember, arrhythmias can develop up to 24 hours after injury. Just because you don't have it at hour 4 doesn't mean you're not going to get it at hour 24. So you should be aware of that when you're deciding to send people home.
Yep.
What about the high risk criteria people?
Yeah. So those are the ones who don't satisfy your low risk criteria. There might be some in the middle. The specific high risk criteria are high voltage injury. So a voltage above 600 volts. That certainly includes folks hit by lightning. Folks who on physical exam have deep burns or any obvious injury as a result of their shock. It turns out that loss of consciousness as a result of getting shocked is a marker of doing poorly into the future. So that's considered one of the high risk criteria as well. For these folks, you're going to want to call 911 because they're going to need more than we can do at urgent care, even if it's just more prolonged observation and some lab work. If it turns out that there's a long wait for the ambulance to get there, or you can do some tests in your center while awaiting transport, you can go ahead and obtain IV access, draw some blood, consider giving IV fluids. You want to check a complete metabolic panel, a CPK, CBC, review that urinalysis that you had talked about, even in low risk patients. High risk patients need that. Give your 12 lead EKG, which all patients need, and then put these high risk patients on a continuous monitor if you have that ability to do so. If you suspect an injury or a fracture or dislocation, which can occur in these patients, then you go ahead and get your x-rays at that time too, while you're waiting for the ambulance to get there. The thing to keep in mind though, is that if you do have the capacity to do these things and you start that workup, you don't want it to delay your transport. So high risk criteria present, you're going to call 911 and then do what you can in terms of evaluation.
Right. So if you're doing that evaluation, you get that EKG and you find an arrhythmia, what should you do?
Well, if it's anything more than PACs or PVCs, which you can see sometimes, we're talking about heart block or non-sustained VT or worse, you're going to be calling 911. You're going to stabilize the patient as needed. If you get IV access, if you have an AED, get it close by. If you have a cardiac monitor to be able to watch the patient on the monitor as you're waiting for the EMS folks to get there, you want to do that. And then you're going to rely on your ACLS algorithms. Again, there's nothing different you would do for somebody with VT or first degree, second degree, third degree heart block as a result of an electrical shock. Your approach is going to be the same as you would for ACLS.
So those people with burns, we're not really going to talk long about that. In the article itself, there was several paragraphs about body surface area and the Parkland fluid resuscitation. And that's a little beyond the scope of this broad podcast. However, the review is included in the article. So if you have some interest in that, I encourage you to go look at the article and refresh your memory on that. It's always good to refresh your memory on the rule of nines and those sorts of things.
Mhm.
What about wound management, Joe? How do we treat electrical burns?
Yeah, you're going to treat them like a thermal burn. There's a nice section in there, like you had said, that reviews the rule of nines, your Parkland formula, a little bit beyond most of the time what we're going to do. Rather than having wide surface burns, unless there was some kind of a conductor on the skin that causes it, you tend to have burns at the entry point and the exit points. And you're going to manage those, again, just like any other burn. If it's true entry wound, it's going to be third degree. It's going to require more than just what we can do in urgent care. In the article, there's a review of burn center referral criteria. And those are important to keep in mind for any burn patient, especially for these. And you can have low grade thermal injuries, but if you have a high grade thermal injury, it's probably going to be somebody to send to the burn center at some point. If they have other systemic injuries, they'll go to the ED and their burn referral can be after that. If you want to know more about managing patients with thermal burns, there is an evidence-based urgent care issue dedicated to that. And it's the July 2022 issue, just from a little over half a year ago. You want to make sure the patient's tetanus is up to date. And now we're having a TD shortage. So where's your TDAP in that case? Tracy, what about kids? Any special concerns with them?
Yeah, actually, there is a lot of kids that have gotten electric shock injuries. It's because it was a toddler chewing on an electrical cord. So, what happens when they get through that plastic and that protective sheath and hit the electricity? They end up with oral commissure burns. So, that would be a burn right at the angle of the mouth, either on one or both, depending upon how they were chewing on the cord. May seem innocuous, but it can result in really significant bleeding due to damage of the labial artery. And an important thing to know is that can be delayed up to 2 weeks. So you're clicking along all good, things look like they're healing, and all of a sudden, boom, that labial artery just lets go with some pretty significant arterial bleeding. So if these burns are minor, you can discharge them, even though they're electrical burns. You want to make sure that the area stays moist. You want to put some topical petroleum jelly on there 3 times per day or more to keep it moist. But we want to make sure that these people have really close follow up, preferably with an ENT person or a plastic surgeon
Mm.
within 2 to 3 days. If you're in an area where, you're 2.5 hours to an ENT or a plastic surgeon, it's probably okay to have that follow-up be with a pediatrician, but just make sure that the family is aware that this really needs some close follow-up to make sure that that labial artery remains intact. Hey, Joe, what about pregnant patients?
Yeah, you're going to want to do your usual fetal assessment as you would if the mom had some trauma. A lot of these patients, particularly if there's fetal viability, so 20 weeks EGA or more, they're going to be going to the ED or to the OB-ED to have extended fetal monitoring. If you can get in touch with the patient's obstetrician, you want to make sure they know what's going on. But most of the patients who are more advanced in their pregnancy are going to need more than we can do in the urgent care, so they'll be going to the ED.
Okay. What about a taser electrical injury? Is that a shock?
Yeah, technically, yes. These things, they have lower amperage, but some of these things are about 50,000 volts, which is incredible. These tasers have a couple of barbed projectiles that shoot from a gun that has the electrical source in it. Those two stick into the suspect or the perp or whoever and give them a little shock. Sometimes it can be incapacitating. It's almost always uncomfortable. Sometimes there are falls related to that. I've actually seen that a couple of times. If somebody gets shot close to the chest or in the anterior torso, they can actually have been some reports of patients getting VFib and then other cardiac injury, which I guess sometimes these patients are amped up on drugs, which can cause cardiac injury, or they may have some underlying myocardial injury themselves, but there have been some reports of that.
All right. So the authors in this article said that anyone shot with a taser should have an EKG and monitoring for 4 to 6 hours. But, I've talked to law enforcement, I've talked to other ED docs, and the law enforcement officers typically just remove the barbs and they rarely seek medical attention for this. And they usually take them right to jail and we never see them. In your ED experience, what do you think?
That's my general sense too. I've seen a couple of these folks through the years. One was wearing a tank top and one of the barbs got stuck in his skin. So a lot of times these are going through clothing. They're designed to go through clothing, but somebody actually had a part of a barb stuck in the shoulder. And then another one actually fell and had a scalp laceration. But in talking to the police, it does seem like they're pretty casual about taking out the barbs and then bringing the patient on to book them.
I actually went and looked up the references on this because I was surprised that they said EKG and monitoring for 4 to 6 hours. And there were a fair amount of case reports about people that had had arrhythmias related to tasers. But it seemed like all of them were either what you said, the barb was into the skin, or it was in close proximity to the chest. If they were shot in the leg or the shoulder, that was probably a little less severe. It actually looks like the taser company had made a statement saying don't aim for center mass chest with these things
Yeah.
because of that risk. But I think it's a very unusual occurrence and not something that occurs routinely. Otherwise, I guess they wouldn't be using the tasers.
Mhm.
So, all right, let's talk about some disposition on these people. So, if you are transferring the patient and that you're going to send to the hospital, probably don't want to have the spouse drive them. Probably want to call EMS, and you want to make sure that you get an ALS crew, someone who's capable of doing advanced cardiac life support and doing that cardiac monitoring, because that's the majority of people that you're going to be sending out, those that you're concerned have a cardiac issue. The following people should be sent to the ED. So those that have a need for extended monitoring, anybody that has an unstable vital sign, anybody who has some significant trauma or burns, and then those people that have some mild but persistent symptoms, the people that are getting some palpitations, they feel anxious, their arm is weak or numb, and then don't forget any lab abnormalities, including myoglobinuria. Now, where I practice, we don't really do any lab work at all, so I'm not going to know about any blood abnormalities. But if the patient goes to the bathroom in the waiting room and says to you, "Why was my urine brown?" You're probably going to want to send that person to the emergency department. And that does indicate that they've had a really more of a significant shock than just a mild little shock. So you're going to want to send them with the ALS crew as well.
Mhm.
So, one last time, let's go
Mhm.
over who's safe to discharge again.
Yeah, it's going to be your low risk patient. So it's going to be a low voltage injury. Patient should be asymptomatic. They shouldn't have had any loss of consciousness. They really shouldn't have any findings on physical exam except for very minor burns. Their EKG will be normal. They should be walking and talking. And again, any patient that does have mild persistent symptoms, you're going to want to watch them for 4 to 6 hours and make sure their EKG is normal. That would be a low risk patient.
This has been a really good review of clinical pathway is present in this article on electrical burns in the urgent care. You can feel free to check that out. All patients should follow up with a PCP. And don't forget that children with those commissure burns should definitely follow up with plastics or ENT in 3 days. If you don't have the availability to do that, certainly they can follow up with you or they can follow up with the pediatrician. So let's review the pearls and the pitfalls and the points.
Sounds good. This is one of the best parts of the issue, that kind of summary that points and pearls present with everyone. I find myself going back and looking at those. I do my CME like 6 months at a time. So I'll keep 6 months of issues out and then go back and look at the points and pearls over time. Points from this particular issue include a characterization of a low voltage injury as under 600 volts, which is really well under the standard current that we have in homes and businesses in the US. Children are more likely to have low voltage injuries. High voltage injuries are more common in occupational situations and therefore involving adults. Dry skin, pretty protective to electrical injuries, but wet skin is not. It's more conductive. And then again, your low risk patients can be sent home with outpatient follow up with their PCP. If the patient's high risk, that's going to be the patient you're going to be transferring to the ED with an ALS level EMS type transport.
Good. And then the pearls, don't forget about possible additional injuries from falling, being thrown, having muscle contractions. It's a real thing. Ear barotrauma, don't forget to look in their ears. Very important. They may have some hearing loss. They may feel some ringing in their ears. Heart blocks or other arrhythmias can occur up to 12 to 24 hours after. And a normal EKG in the first hour is not clearing the patient. They still could have some difficulties later on. So just because your EKG was normal initially does not mean that they're out of the woods 100% just yet. Oral commissure burns, again, can't stress this enough. ENT or plastics evaluation. And make sure you see the patient walk out the door. You want to make sure that they're capable of walking before they're discharged. If they have to be wheeled out in a wheelchair, it probably means they're more injured than what you originally thought, and they should be going to the hospital.
And again, remembering pregnant patients who undergo electrical injury should be assessed by their OB. You're going to do your normal fetal assessment, but patients who are 20 weeks or above, even if they look good, they're going to need extended fetal monitoring. Those patients who do make their way to us with Taser injuries should be treated like other electrical injury type patients. They're going to have an EKG and monitoring. And then remember your burn center criteria for referral for patients with more severe burns on the face, burns on the hand, those sorts of things.
Perfect. All right, so I think that's a wrap for this edition. Remember to check out the full article on EB medicine as well as the clinical pathway on our website.
And we will see you next month on the next edition of the EBM Urgentology podcast.
I want to thank everybody for listening to this month's evidence-based urgentology podcast. Just a reminder that subscribers can go to ebmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to the site, that's ebmedicine.net, to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.